Welcome to Tuesday lunch with Rita. Today, our distinguished guest will answer an interesting question: which patients with IEI should be referred to HSCT? I am Martine Pergent, the president of IPOPI, and it will be my great pleasure to co-moderate this webinar with Professor Bénédicte Neven. Bénédicte, would you like to introduce yourself?
Yes, thank you, Martine. So I'm a pediatrician in Necker Children's Hospital in Paris, and I'm taking care of patients with inborn errors of immunity, and I have also activities in bone marrow transplantation in this patient. And today I'm very pleased to introduce our two speakers. First, Robbert Bredius, who is a pediatrician in Leiden in the Netherlands. He has a very large experience in transplantation of patient with a non-malignant disease, and Carsten Speckmann, who is also a pediatrician in Freiburg in Germany, and also very experienced in transplantation for patients with inborn errors of immunity. So they will both introduce the topics and give us some ideas, and also ask questions about how to deal these question, when to refer, and when to go for transplantation in this patient. So if you have questions that we will discuss at the end, please write your comment and questions in the section on the screen. So Carsten, the floor is yours.
Yes, thank you very much, Martine and Bénédicte, for the kind introduction. For technical reasons, you will not be able to see me while I give my talk because the camera shuts off when I'm in presentation mode, but I will be visible later during the Q&A session. So today's topic of the webinar is which patients with inborn errors of immunity should be referred of HSCT. So very tough questions, and we will probably not provide clear answers, but what we want to do is take you a little bit along the journey that we are on when discussing these issues with patients and families. So we want to discuss with you today how to set an indication for HSCT, and I will start with working my way along the EBMT categorization that has been established for this. We will discuss clinical examples, both pediatric and adolescent cases, showing you that these very clear categorizations are sometimes not so clear in the real life clinical setting. We want to discuss some of the dilemma situations that we are facing in patients with inborn errors of immunity, for example, regarding incomplete study data that we have for this situation, and want to review aspects that you may want to consider when counseling patients and families with these diseases. So if we look into the EBMT categorizations for indications, and there's a very nice paper that I referenced down here that I highly recommend to have a read. You can distinguish different levels of evidence, so to say, where HSCT is indicated. So the highest level would be situations where HSCT is considered standard of care. So an indication that is well defined and where results of HSCT as treatment are favorable or even superior to non-HSCT approaches. So there are situations, of course, for example, in leukemia treatment, where this is very well defined. And there's also some situation where this is very well defined and very clear in inborn errors of immunity. I will provide you with an example in the first case. So this is the history of a male newborn who had an urgent positive tract newborn screening, was then sent to confirmatory testing, and was identified to have a T-B+ SCID on the basis of a known pathological mutation in JAK3. I think we can all agree here that in this situation, transplantation is considered standard of care, even in a preemptive setting. Now, there are not too many situations where this is so clear. FHL might be another situation. So a situation where there's no alternative treatment to cure the disease or to help the patient long term. In our daily routine, however, we are more often confronted with situations where HSCT can be rather considered to be a clinical option. That means it's an indication for which the results of small patient cohorts show efficacy and acceptable toxicity and TRM, but confirmatory randomized studies are often missing. And there might be even situations where conditions are very rare, where we lack data, where we must consider HSCT still to be a developmental approach, meaning that it's an indication where the experience is very limited and additional research is needed to define the role of HSCT, for example, in contrast to other therapies like targeted therapies that are becoming also increasingly available. And then there are situations where HSCT is considered to be generally not recommended, but with more advances also, for example, in the field of conditioning regimens that become less and less toxic, also we are coming into a situation where we might open here doors that were closed for many years. To discuss these and a few other aspects, we selected some case examples to introduce you to our daily work and considerations that we make in these situations. So case number 2 is the history of an 8-month-old male infant with a previous uneventful history. He was acutely admitted to ICU because of respiratory failure and was identified to have a pneumocystis pneumonia. He recovered fully after a 3-week course of cotrimoxazole without sequelae and was identified to have normal T and B cell numbers, but to have significantly reduced IgG. IgM was present. He had a pathological mutation in CD40 ligand, and further functional investigation proved that finding to be relevant. You see here a healthy control with nice CD40 ligand upregulation upon stimulation in the T cells, which the patient was not capable to do. So a very clear situation of CD40 ligand deficiency. So we had the patient referred to us to be evaluated, and a donor search identified that there was no suitable family donor, and an international search identified the best available donor to be a 9 out of 10 mismatched unrelated donor with a C allele mismatch. So no full match donor available for this child. So here comes the first question to you. And we thought to make this webinar a bit interactive and to get you involved in the decision process that we make. So you will be able to see these questions, and we address this question to you. Would you perform HSCT in this patient, or would you rather go for watch and wait? So we kindly ask you to vote, and we'll be interested to see how you would proceed in this situation. You should be able to see the polls, and please type in your decision, and we will address this then in the further course of the webinar.
Let's wait a few more seconds because I see people are still voting.
Okay, so I don't know if you probably also see the results. It's a 50-50 situation almost. 57 of you would undergo transplantation, and 43 would watch and wait and follow a prophylactic regimen. Okay, so what do we know from the studies? What do we know from literature? I hope you can see my slides again. So there has been a very nice study published by Francisca Perua on behalf of the Inborn Error Working Party in JACI 2019 that investigated the outcome of transplantation in a fairly large cohort for an inborn error. 130 patients who underwent HSCT for CD40 ligand deficiency were evaluated. And Francesca's data shows that HSCT outcome is actually quite favorable, in particular if carried out in more recent years, in children that were younger than 10 years, and in children that had no organ damage. Now, our patient did have a severe manifestation with this lung disease, but the disease was quickly identified and treated appropriately, and the patient recovered fully without sequelae, so no significant organ damage. Francesca's data also suggests that overall survival and disease-free survival is also quite favorable if you apply a myeloablative regimen in the conditioning process and if you transplant early, so if HSCT is performed within 2 years from diagnosis. Event-free survival was associated if you had a matched sibling donor, which we did not have in our case, and if you used bone marrow as a stem cell source. So we here in Freiburg do strongly believe that CD40 ligand, as it is a combined immunodeficiency and not only an antibody deficiency, that you should opt for transplantation, in particular if patients have an early and severe clinical presentation, as in the SCID-like phenotype in this patient. So we moved on with transplantation at 11 months of age, 3 months after the diagnosis. The course was really uncomplicated. We used a myeloablative, so-called reduced toxicity conditioning, consistent of thiatepa, treosulfan, fludarabine, and serotherapy with ATG. We used bone marrow from this 9 out of 10 donor. We saw early engraftment, and the patient had consecutively full donor chimerism. At last follow-up, the patient was 10 years old, had normal development and no disease residues, so full cure and successful treatment of his underlying condition. Let's look into another case. So this is the story now of an 8-year-old boy who started to have clinical symptoms at age 3 with recurrent otitis media and bacterial pneumonias that required IV antibiotic treatment. Also, this patient had normal T and B cell numbers at investigation at 6 years of age, had significantly reduced IgG. IgM was elevated. He was put on subcutaneous immunoglobulin replacement, was clinically stable over the past 2 years, had no problems at all, and was given a clinical diagnosis of CVID. He was referred for further evaluation at 8 years, and a genetic investigation by next-generation sequencing identified also that this patient had a pathological mutation in CD40 ligand. Again, also this patient did not have a family donor, and the best available donor in a donor search was again a 9 out of 10 mismatched unrelated donor. So same disease, but a milder clinical presentation in context of a probably more leaky mutation. Same question to you again. What would you do? Perform HSCT or watch and wait? So you will see again this poll, and you can pick your decision and we can discuss afterwards. So I hope the voting process is working as well as it was for the first question.
Yes, it works just fine. People are still voting. Let's wait a little bit.
Yes. Okay, so here the picture is a bit different. Now 2/3 of you would watch and wait, and 1/3 would perform HSCT, so a broader part of the audience would follow a conservative treatment approach. Well, and if you look into literature, there is certainly also data that can be interpreted in a way to support this approach. So there's another paper published in the same year, also in JARCI, put together by Teresa de la Morena, looking into the long-term outcome in 176 patients with CD40 ligand deficiency. And what is special about this cohort here is that it did not only look into transplanted patients. Teresa looked into 109 patients also that did not underwent HSCT, and 67 patients were transplanted. And if you plot these survival curves next to each other, it's certainly a tough data situation. Teresa concluded actually that there was no difference seen in survival observed in patients treated with or without HSCT across all diagnosis years. That was a wide range between the 1960s to 2013. However, survivors treated with HSCT did experience a somewhat greater well-being, and among patients treated with HSCT, in those that were treated early, that was associated with improved survival. So certainly a tough data situation when counseling parents. Nonetheless, this is a situation where more recent years were not included, and I'd like to carry you on with the case and how we decided to treat this patient. Now, as I said before, here in our center, we do have a strong belief that if a patient is in a good clinical condition and has a disease that probably can be rather considered a combined immunodeficiency as CD40 ligand, we do favor transplantation. So we went on with transplantation also in this patient with this more CVID phenotype clinically, because it is the only treatment that really provides curative treatment option, and counseled the family accordingly. We used the same myeloablative reduced toxicity conditioning, used bone marrow from a 9 out of 10 donor, and also this patient early engraftment and full donor chimerism. However, this patient experienced severe immune-mediated anemia and thrombocytopenia from day 60 onward. He had no treatment response, neither to steroids, nor rituximab, daratumumab, plasmapheresis, and many further used immunosuppressant, and the patient sadly deceased at day 112 from this treatment-related mortality. So let's sum up some teaching points from these cases. As transplanters, naturally, we want to believe that patients undergoing HSCT for an inborn error of immunity will have a normal lifespan with a fully corrected immune system. However, we must anticipate and also counsel families accordingly that we make these decisions on the basis of cohort data. And although these assumptions are right, if we apply these to the entire cohort, there will of course always be TRM, even in patients with little comorbidities pre-HSCT. So our decision to move on with HSCT, although it might be right for the entire cohort of patients, will necessarily be wrong for individual patients. And we are also just beginning to understand the late effects of HSCT, that this fully correction, of course, also need careful long-term surveillance. Moreover, in inborn errors of immunity, our study knowledge is often based on small numbers of patients, even in inborn errors that we consider quite common. And our data is often retrospective and covers small time windows, and we're just starting to have more prospective registry data available. We are often looking into data that is based on historic and not the current practice. For example, there have been great advances in haplotransplantation, offering early transplantation also in situation where there's no available donor, and many of the current studies do not implement this more advanced haplo experience. But there's also increasingly, not for the disease that we just discussed, but for others like APDS syndromes with the development of PI3 kinase delta inhibitors or CTLA4 fusion proteins for LRBR deficiency or CTLA4 deficiency, more targeted and alternative therapies that may be used as a bridge to transplant, but also as an alternative conservative treatment approach. And there's also new antimicrobial agents being developed, offering both better outcome and treatment option in transplant situation, but also adjusted prophylactic regimens and in the non-transplant setting. So I hope I could show you a little bit that in our real-life counseling situation, we are often facing situation where the transplant indication is not always standard of care, but where we are dealing with diseases that are probably sitting between standard of care and situation where HSCT is a clinical option. We discussed this on 2 case examples for CD40 ligand, but it's also true for other here listed and further diseases. These diseases often have variable clinical phenotypes, sometimes even in patients with the same mutation in the same family. There are situations where this can be better anticipated, for example, in Wiskott-Aldrich disease or CGD, where there's very good genotype-phenotype correlation or good functional analysis that can give us some guidance and help us to foretell better the natural course of the patient without transplantation to give better advice to the families. The timing of HSCT is important, and the age of the patient. Generally speaking, for many of these diseases, the earlier, the better, the younger, the better, and we need more prospective data to support these considerations. There are more diseases that have been reported over the past years, some like CTLA-4 LRBA deficiency, where there are also novel pharmacological treatments available that need to be compared, and therefore indication for transplantation must be rather considered to be developmental. And we're also making great progress to make our treatments less toxic, making treatments generally safer, but also enabling us to think about maybe further indications that we didn't dare to think a couple of years ago. I will now hand over to Robbert, who will discuss some of these aspects in another case, and we can then in the end wrap up also maybe some open points to be discussed.
Hello, yes, here Robbert. I'd like to share my screen. Oh, how do I? Oh, good.
Yeah, it's working. We see your slide.
It's working already. You see the presentation modus? The presentation now?
Yes, we see it, but in such a format that we see also the next slide. Can you share only the diaporama on one slide, just like last time?
This is difficult for me. No. You see the not the presentation modus.
Now we do not see your screen at all.
Oh goodness. And now?
Yes. What happens if you click on the on the bottom left? There is a screen icon next to the on the no.
People can see your screen.
Yes, that is correct. But we only see what you see now, basically.
Oh yes, you see the other.
Maybe, yeah. Hold on. No, not this one. The one on the left. Let's try and click on that. Yeah.
This one.
Yes.
No.
Let's see. No. Oh, it worked fine last time. Oh, there you go. Perfect.
Ah, goodness.
Thank you, Robert. Sorry.
Okay, so I'm Robbert Bredius, I'm a pediatrician, and I'm going to present case number 4. And this is I know this girl from her youth, before she was transferred to the adult doctors, and she was known with, from the age of 10, problems with immune thrombocytopenia and later on neuro SLE, which was intensely treated with steroids and rituximab and cyclophosphamide. She received a splenectomy, and we did consider an autologous transplantation at that time, but we eventually decided not to do that. And she was at that time then in a pretty stable condition transferred to our adult colleagues. And there she developed further problems with recurrent infections, hypogammaglobulinemia treated with immunoglobulins, and she started to collect a whole bunch of other problematic diseases such as bronchiectasis, recurrent pulmonary infections, autoimmune nephritis, urinary tract infections, autoimmune hepatitis, pancreas dysfunction with diabetes eventually, and norovirus in her gut for a couple years. And she was not doing too well. And now we come to the question to you guys: what would you do? Would you consider a transplantation at this stage, or would you want to wait and see and consider conservative treatment? And I presume you're now trying to vote, eh?
Yes, people are voting right now. Let's wait a bit.
So would you, in this stage, perform a transplantation, or wait and see and keep on with this conservative treatment and try to keep her as stable as possible? This is probably not a very easy decision at this stage. Shall we continue, or is it still open for voting?
People are still voting, so let's wait again a bit more, just so we gather most people vote. It's a very close result, you'll see.
Okay.
Okay, yeah, I think now most people have voted. Let's share the results. There you go.
Okay, and I'm not seeing the results, but you say,
it's a perfect 50-50%.
50, yeah, and so the decision here is not so easy because you don't have a diagnosis. And the fact at this stage started that they did a whole exome sequencing and they did further genetic testing, and at this stage they found a genetic diagnosis, and the diagnosis was CTLA4 haploinsufficiency, so the disease that Carsten already alluded to, which is an immune dysregulatory problem, a PIRD, a primary immune dysregulatory disorder, and it's the same as LRBA, a disease that results in all kinds of autoimmunity. And the question now is, again, we do have a genetic diagnosis now, but what would you do with this diagnosis and this patient? Would you now decide to go for a transplantation, or would you still wait and see or start a targeted treatment? Of course, then you should know that is there targeted treatment or not? And I can already tell you there is a possibility of targeted treatment, but still you have a genetic diagnosis now. You know this girl has a primary immune defect, so you could also decide to go for a transplantation. It's not an easy decision. And I think many doctors, adult doctors, pediatricians would hesitate to decide what to do. How is the polling going?
So most people have voted, and I'm sharing the results. And 63% would watch and wait, while 37% would perform HSCT. So
with this genetic diagnosis, now people decide to watch and wait, and maybe even start interfering this problem with the immune problem with CTLA4 haploinsufficiency with a treatment such as abatacept. Here you see a publication from a Turkish group, a large group of patients with CTLA4 and LRBA deficiency, recently published. And you see on the left panel, you see the survival curve of the patients treated with immune suppressants compared to the transplantation outcome. This was reported for the LRBA group because the CTLA4 group was too small, but you see that the non-abatacept immune suppressive treatment is not very superior to the HSCT. In fact, HSCT is quite a bit better. But if you then on the right panel look at the abatacept, which is a modern drug, doing pretty well compared also to HSCT. The curves are almost overlapping, and there's no significant difference, of course, if you see the eventual outcome. So this is a tough call. So this girl was diagnosed now with her CTLA4 haploinsufficiency, and she was put on belatacept, which is the same type of drug as the other one. And at this stage, she was not doing too well, and we eventually decided, together with the adult doctors and with the patient herself, to go for a unrelated donor transplantation. She had a 10 out of 10 matched donor available. She was treated with reduced intensity conditioning. She had quite a few complications, acute and chronic kidney issues. She had a drug-induced liver injury. She had a Streptococcus mitis sepsis, for which she was treated in the ICU for a couple of days. And then after a year, she was, of course, recovering, and she developed chronic inflammatory demyelinating neuropathy in the legs and arms, which was then treated with immunoglobulins. And now she's 2 years out of transplant, completely donor chimera. Well, now the question comes, do you consider this transplant a successful, yes or no? And then the next question will be, does the patient think this transplantation is successful? But first, you guys. How is it going?
Votes are still incoming, but I think we'll be ready to close this soon. Let's wait 5 seconds. All right, we have the results to share. And for this question, we have 62 no, while 38% think yes. So the majority of no's.
So there's a minor, sort of 40% approximately find it no success. And now the same question, do you think the patient considers this a success? Well, maybe you find this a similar question as the previous one, so we might have the same sort of result, but we will see. She came in with all kinds of norovirus, immunoglobulin supplementation. She came in with bronchiectasis, and she comes out with peripheral neuropathy, treated with immunoglobulins. But do you think she's finding this a success?
Okay, the results are in. We have 24% yes, and 76% no.
Okay, so you think that the patient is even less optimistic about the outcome of this transplant? Well, the opposite is true. She found this a very successful transplantation. She's gone for skydiving at the time point of 1 year approximately after transplantation, and she, even though she has issues at the moment, she still finds it a success. And she changed, of course, different symptoms pre-transplant and post-transplant, but she finds this eventually a success. And what determines a success? Of course, there's a medical immunological outcome parameters. There's, of course, the patient, what the patient thinks about it. patient reported outcome and experience, and of course you have prospective studies that tell whether a transplant is a success in general for a specific group of patients in a cohort of disease. So to discuss an indication with a patient for HSCT in immune inborn errors is really a tough call. You have to determine the risk of the disease and the individual status of the patient really carefully, together with the patient, together with your colleagues. You have to know a little bit about the natural course of the disease, which can be taught from cohort studies. But you really have to have an idea about the natural disease course. So then you have to know what kind of outcome of the HSCT might be anticipated. And for that, you have to know the comorbidities, the donor availability, and you can then estimate your TRM, your transplant-related mortality and late effects. Expected outcome, of course, from a physician point of view, but also from a patient point of view, is then important. And expected risk and outcome results in non-SCT strategies has to be known. So you have to know what the alternative treatment is doing and how are the long-term outcome of these procedures and these strategies. So targeted therapy, for instance, for LRBA or CTLA4, you have to know the long-term outcome of that. And also for the other issues in APDS and JAK-STAT inhibition, of course, is also a possibility of treatment, but you have to know what the 5, 10, 15-year outcome of these strategies is. Okay, thank you very much. Come to the end of the presentation now.
Thank you very much to both of you. I think you gave a very, very nice overview of all the questions we are facing in our everyday clinics. So please, if you have questions or comments, write in the question section of your screen, and we will be very happy to translate the questions to Robbert and Carsten. As an immunologist and also a transplanter in this disease, I think from my point of view, the most difficult part of the transplantation is usually, or for most of the disease, is the decision to go to transplantation. For many diseases, we know that the best is to go to transplant, but sometimes it's hard to convince the family, to counsel the family to build the decision to go to transplantation. And CD40 ligand is a very, very nice example, I think, because as Carsten, we are convinced it's a combined immune deficiency and it's not a B cell deficiency. We know that when the patient grow up, they may be infected by cryptosporidium, and they may develop liver disease, and transplantation will become very, very difficult. But we know also that TRM is always a risk for these patients. And the second example of Carsten, very, I wouldn't say nicely because the outcome is not nice, but exemplified the difficulty of the decision. Actually, I would have made the same decision, and I think I would have driven the patient to transplantation. And when the outcome is not good, it's always extremely difficult. But we have to keep in mind the severity of the disease we are dealing with. Another comment coming from my practice, I think it's extremely important to have a very strong knowledge of the disease and the transplantation matters, and I think doing both activities is really important to give the best advice to the patient, knowing the natural history of the disease, how to deal with the disease, when to consider transplantation, and how to consider transplantation. So I think these examples that you gave us are very, very important and teach us how to deal with the decision and how difficult it could be. I think the patient perspective is also extremely important. I don't know, Martine, if you want to comment on this.
Yeah. Thank you for the presentation. I think it was great. Indeed, this is really a difficult decision from the families to go for transplant. Nevertheless, I would like to challenge you a little bit on one question. It's just about XLA, because in some parts of the world we hear about XLA transplantation, and there even the family, they say maybe this is better to go to that kind of tough treatment rather than not being able to access to the prophylactic treatment. So I'd like to hear you about that. I know this is really not established so far, but maybe you would make the point of that. I don't know. Yeah,
Shall I start, and then Bénédicte and Robbert can maybe step in? So for XLA, I would certainly say that is not a standard indication. It is even, I mean, I would also agree it's not in all patients an exclusive antibody deficiency. There's even more phenotypic diversity to certain extremes of the spectrum than in CD40 ligand. I think so with these genetic diagnoses, nonetheless, there is an option for transplantation. And generally, and that's not only true for XLA, but many of the inborn errors, I think when you counsel families or have that decision, having a discussion on indication, it's not that you have to make a final decision at one point. If you have a patient with XLA, and that is not having severe problems, I think it's fair enough to say that the routine treatment is antibody replacement therapy. But that question of transplant, yes or no, might be coming up again and again, and it needs to be reviewed, let's say, in yearly intervals, or if there are immune dysregulatory problems that you cannot manage very well. And if you are one of these XLA patients who has antibody deficiency, that is well treatable and well controllable, but where you are running into several immune dysregulatory issues that requires very intense immunosuppressive treatment that then maybe don't work very well, then I think it's time to consider transplantation, and outcome data is also, that's probably a situation again, not needing to jump into transplant right away, but also not to wait too long and not to be too afraid to jump into transplantation. Just maybe one last aspect in different disease, but also what we are experiencing now over the past years is that we have now young adults coming to us asking for transplantation where their parents didn't want to jump into transplantation. Either because they didn't want to make that decision in the past, or because in the past there was no good available donor, and the situation is still the same, but we now have new treatment options with new haplo regimens, etc. And there are many of these patients who have a long history with severe sequelae who then say, I want to make a decision for myself now, similar to maybe the lady that Robbert introduced, and that's sometimes for us an easier decision because it's a more consented decision really with the patient who knows what is life with the disease. But it's always a tough decision, of course, in these non-clear indication. Nonetheless, it's our position to position ourselves to open strategies and have the family really good on board on that decision. So coming back to XLA, I wouldn't exclude that, but it's certainly not a standard of care. But there are also certainly patients where it is a very good treatment option.
Thank you very much.
I fully agree with Carsten. And of course, the patient history, adding up all kinds of symptoms and problems will eventually help you in this very difficult decisions. There's quite a few diseases. CGD is maybe one where young adults start to decide for themselves, even though the doctors that as pediatricians didn't want to proceed to transplant, and they as a young adult they really want to continue that. So we see that indeed, and it's easier in a young adult than when a father, mother, child is sort of as a three.
We see that as well with the STAT3 mutation when adolescents
Similar. Yeah.
anymore and they want to go to transplant despite the parents don't want.
Yeah.
I think I'm fully in line with you, and XLA is not such a benign disease that we thought, and more we see a complication and liver disease also. So I think, as you explained, Carsten, there are few situations where the transplantation can be considered. Now we have a question from Tanya. Would you perform 10 out of 10 unrelated donor transplant for a child with a low TREC at newborn screening and 200 CD4 at the age of 3? No major clinical problems other than minor viral infection. So maybe Rob, your turn.
Yeah, this is not so easy. I presume there's no genetic diagnosis here. So there's
it's not
genetic.
by Tanya, but I guess there is no molecular diagnosis. I don't know if it was performed or not.
Yeah, I find this difficult, I think. Maybe if the child is doing perfectly well, if he's on prophylactic drugs, such as cotrimoxazole, you may not run into problems and you can a little bit wait and see, but it's tricky. Carsten, what do you think?
The patient has cartillar hair hypoplasia, so maybe opinion.
Okay.
Does it also difficult? We transplanted these patients.
I would go for so. I think that's an important piece of information. I find it difficult to make a transplant decision exclusively on a CD4 count. So if it would have been a genetic undefined situation, of course, that's important message that I want to make. In your screen, of course, you must consider it could be a thymic defect. So that's one important issue. If you don't have a genetic diagnosis, don't jump too early into transplant. You have to at least functionally evaluate the situation. T-cell proliferation is an important issue. Nonetheless, I mean, cartilage hair hypoplasia is a clear genetic diagnosis. It's a transplantable condition. Again, there will be variable attitudes from center to center. Our attitude here generally would be rather transplantation, let's put it that way. Again, it depends probably also, we know for these syndromal diseases that they might be stabilizing over time. So have very low CD4 counts after birth and then improving. But here, it is. I would consider this probably rather a leaky skid situation. I wouldn't expect that things improve necessarily over time. There will be infectious challenges to come up. EBV might be a problem. We have seen a child with very nasty non-Hodgkin lymphoma, EBV positive, in a cartilage hair hypoplasia sitting. So without even knowing all the details, but with these few points, I would be probably rather pro-transplant.
Yeah, I fully agree with you, and they can also develop autoimmunity with over time and lymphoma. So I think in such situation, we would also decide to go to transplantation. There was another question from Johannes. Does it make sense to distinguish between different donor type, sibling, haplo, 10 out of 10, 9 out of 10 unrelated donor, when considering allo transplants, yes or no? Interesting question. Carsten?
Yeah. This is also a very interesting question. Carsten, you can go first. Okay, yeah. I think if you have a healthy sibling, HLA identical healthy sibling without carrier state of the disease, I think you would rather proceed easier to a transplant than with a 9 or even less matched donor needing cyclophosphamide or other tricks to perform the transplant appropriately. So the SIB transplants are still really a bit easier, I find, than. And then on the other hand, if you have a haplo or 8 out of 10, that wouldn't make a huge difference in our hands anymore. Maybe 10 out of 10 is still slightly better, but it's, yeah. We would consider the transplant option, the donor options in our discussions with the patient.
Yes, very strongly include that in our discussion here as well. I mean, of course, there are obviously in the sibling question sometimes also ethical dilemmas. So if you have a very young sibling, very lightweight, if you have the situation in a let's say X-linked condition, you could have a sister who's carrier, maybe have skewing, who's a minor. Do you want to address this? It must be weighed carefully and put into the discussion also. And again, there might be also regulatory and local center differences on how to deal with these issues. But as Robbert pointed out, that's certainly the choice of donor in general is of course very important. We've seen this also a bit in the data that we presented, that it has impact on complications. Of course, it had impact in the past simply also on readily availability. And I think that has a bit overcome with the availability of better haplo procedures. And I think that's also, it's a very important message that in most situations, there are suitable donors for every patient. There are exceptions, special situations, but generally the possibility of having a donor, Robbert pointed to this, PT-Cy regimen or other depletion option, I think it's not that much of a limitation as it was in the past. Nonetheless, having a sibling donor is still a nice thing.
Fully agree. Even though I think the choice of the donor is less and less an important point in the decision to go to transplant. If you really consider that the transplant need to be done for a patient, haplo settings are a good option with the various approach, TCR-alpha-beta or in vivo depletion with the PTCY. And in both option, if you have a good clinical status of the recipient, the procedures can be affordable for the patient. So it's count, of course, it's an important point to make the decision, but less and less as compared to the past, I think, thanks to the new platform we have for haplo. But thank you for this very important question. I think that the question we had raised very nice point and very nice important discussion that we have in our daily practice. I don't know if Carsten, Rob, you want to add a few comments, or we are close to the end of this session.
Now, as you pointed out in the beginning, the decision to go for a transplantation is a really big one. You need a lot of talks with patients, parents, doctors, colleagues, and so on. It's a big decision. So that's what you started up with. Yeah.
And don't take the decision alone. It's good to talk with other people.
Sure. Yeah.
It is. I think it's up to us physicians how to position ourselves clearly towards families. I think it's not only about demonstrating them option A and B and then have them pick one. I think it's our duty to know the diseases very well and then make clear suggestions. But again, as I said, it's never that families may need time and patience. It's not that doors are closing. I think it's important, if there's a disease that's treatable by transplantation, to think about it, evaluate the patient, offer that treatment, but also be honest to the patients that there is TRM. I think that's, as Robbert pointed out, it takes a lot of and long discussions, and that's very important because it's a very powerful treatment, but also potentially dangerous, and you have to have everybody aboard. And usually, I think then it's a very good approach for many of these diseases. And as you pointed out, Bénédicte, there are less and less limitations in terms of donor choice, and it's a treatment that's generally available for most of these conditions.
And may I add that it's very important also maybe to encourage the patients to go to centers where there is a lot of knowledge on both PID or IEI and transplant. Because the more you do, the best you are, I think. And this is good that the patient understand that.
I can only support your comments. I think we will close this session. I really want to thank Carsten and Robbert for your very nice presentation. Thank you, Martine, for being with us. I think I have two advertisements for today. First, the next ERN-RITA webinar will be set for the 5th of March, and it will be about autoinflammatory disease, how to recognize autoinflammatory diseases. And I would like also to advertise for the spring school of the Inborn Errors Working Party of EBMT that will be set in June. And end of June, if you want to know everything about cellular therapy and bone marrow transplantation in inborn errors of immunity, please come. You will have all the information on the EBMT website. So thank you very much for being with us today, and I wish you a very good afternoon. Bye.
Thank you. Bye-bye.